if you have any question. Let me just very briefly introduce Dr. Thomas Flegel, and really thank you very much that he has not cancelled his appearance here and we can continue with the seminar, because we all know it's a difficult situation. So thank you very much for joining us, and he's from University Leipzig, and I have asked him to introduce himself a little bit more to you guys so that we know who he is, and I'm sure the program you all have received, and over to you, Thomas.
Yeah. Thanks a lot, Andreas. We'll come back to that later. Before I actually start with my topic here, I have written down a few things before I forget them. Obviously, my native language is not English, as everybody can hear, so I apologize for that in advance, but I hope it will be good enough that everybody can understand what I'm saying. The other thing is that I'm here to present some neurological topics, but the way I see my job here is not only that I present things to you. If you have other experiences, we can join a discussion, or if you have questions, feel free to ask. It's not as important that we get through the entire program. I believe it's more important that at the end of this day, you leave this room with a feeling, okay, I have learned something that helps me with my work. That's more important to me than being able to talk about everything. And the last point on my list here is timing. I usually can predict very well if I have 1 or 2 talks to stay in time. If it is an entire day, that gets a little bit more difficult. So if I speak longer than I'm supposed to, then you have to interrupt me, throw something at me or something like that, and then I stop. Sometimes I get lost when I keep talking and I don't find an end. So you can interrupt me at any point. Okay. Coming back to neurology. Usually neurology starts with a neurological examination, and that's why that's our first topic. I have included a few videos there that are not mine. We had a student project where students actually took videos of the neurological examination in a more standardized way. So I'm using those videos, and I just would like to acknowledge those students. As I was asked to introduce myself, yeah, that's really me. Sometimes I get asked, when did you decide to become a veterinarian? Very late. So that just happened. I probably decided when I was 18 or something around that time that I have to study something, and veterinary medicine didn't sound too bad. So before I didn't have any connection to veterinary medicine. So I did start veterinary medicine in Germany, in Berlin. Then I actually did work for quite a while in university settings as well as in private hospitals in Berlin. And at some point I decided I want to specialize, and I did specialize in neurology because my impression was that it's probably the most complicated part, so why not trying that? And I went to the US for 3 days, and at the end I became this diploma of the American College of Veterinary Internal Medicine Specialty in Neurology. So that's the title. If you are a neurologist, a board certified neurologist, as you have similar titles in surgery and internal medicine, we have that in neurology as well. And later I got the diploma of the European College of Veterinary Neurology as well, and for quite a while I was the president. I'm now the past president, meaning I used to be the president, and now I'm still guiding a little bit the college. So that's basically the reason why I believe I can stand here and talk to you about neurology. That's the only intention why I did show those. At least in Germany, many veterinarians, if they see a case that has supposedly some neurological deficits, they feel more or less lost. And one of the first things that probably happened is that I look for the phone number, where can I refer that case to, because I don't have any clue about neurology. I'm not sure if you feel, or some of you feel similar. That's the way for our clinicians in Germany. And yes, neurology can be quite complicated, and I guess everybody still remembers the time of the veterinary school when we had to learn the anatomy of the brain. Anatomy of the brain, for me, it was one thick book. I had to study for anatomy, and I believe it doesn't have to be so difficult. The story I'm telling now, I don't make up that story, it's really true. When it came to the examination, when I was a student and it came to the examination in veterinary anatomy, I realized that I cannot study everything. So I had to skip a major part of anatomy. And guess which part I skipped? I didn't learn anything about the brain. And it worked. Now I'm standing here and I'm a neurologist. So it hasn't been so difficult. It can be difficult, we can talk about neurology in detail, and it can be difficult, but I believe it can be quite simple as well, and that's what I will be trying today. Neurology in the times of MRI. That's in our hospital. We have a 3 Tesla MRI scanner, and veterinary neurology more or less developed with CT and MRI, but that somehow led to the impression that we only need MRI, and MRI is solving all our problems. We just put the patient into the scanner, and at the end we get a result. And that's not the way it works. My daily work starts with normal instruments, with instruments that actually have been around more or less for quite a while. So I use instruments to touch, to pinch the patient, to see if they can feel pain. So it's not the MRI where neurology starts, it's actually those instruments, or probably it's more likely like that. I use a reflex hammer, and I actually like this one. We need a light source, and we need some hemostats. That's the primary equipment of a neurologist, and not the MRI. The MRI may come later, It doesn't have to be the case on all patients, but that's where neurology starts. There are different types of reflex hammers, and that doesn't mean that it has to be this one. It's called the reflex hammer after Taylor. So there are different types, and you can use whatever you want to if you want to do neurology. But I recommend to stick with one of those hammers. So if you decide to use this one, then you probably should keep using this one. And for those of you who like it more fancy, there are other types of reflex hammers as well. In my opinion, the neurological examination has 3 parts we have to go through. The first one is obviously signalement and history. That's only part of my neurological examination. Then the second part is the part where I do not touch the patient yet. I'm just observing it. And the final part is actually that part where we perform certain tests with the patient. Let's start with signalement and history. And before I come to that, I would like to talk about that pattern recognition. When I say signalement in history, I'm really pressing our veterinarians and our students to start the presentation of a patient with a signalement. What type of animal is that? What breed? What species? Let's say the opposite. What species? What breed? Is it female? Is it male? What age? Because all that information does influence our differential diagnosis. And that's where I start. And sometimes I hear the story of a patient, and I know if it is this breed at that age, it's most likely this disease. So I even don't have to examine the patient. That's what we call pattern recognition. And everybody does that in daily practice. What does that have to do with pattern recognition? That's an interesting study that was really published recently. they did look at pigeons. How well do they do in interpreting slides of histopathology of breast cancer? So they trained pigeons to recognize the benign or the malignant slides, and they compared the results of the pigeons with pathologists. And the pigeons were nearly as good as the pathologists. Yeah? They were not as good as a pathologist because they have been trained medicine. No, they didn't know obviously anything about medicine. But they were able to recognize certain patterns. And that's something that works for us as well. For some diseases, you even do not have to know anything about neurology in detail. You just have to recognize the pattern. And you can solve quite some cases by pattern recognition. And here I have an example. There is a beagle with cervical pain. And we can see that quite obviously. This poor dog doesn't want to move its neck. And depending on the age of that beagle, if it is a young beagle below 1 year of age with cervical pain, it's most likely to be steroid-responsive meningitis arteritis. I would even say it's a diagnosis until proven otherwise. Even without examination of the patient. If this beagle is older than 4 years, your first differential diagnosis is intervertebral disc disease. Why does that disease not apply in this age group anymore? Because it just does not happen in that age group. So it's just pattern recognition. You do not have to know anything about cervical disc disease. You do not have to know anything about that fancy disease here, steroid-responsive meningitis. You have to know a young beagle with cervical pain has probably that disease. That happens in certain cases. It does not happen in all. But you can train yourself to be better in pattern recognition, and that's why I believe signalement history is so important.
Yes.
The second step is observing the patient. And one thing we want to observe first before we touch the patient is the mentation. Do we have a normal mentation? Is it reduced? Is the patient stuporous or comatose? Those two actually look pretty much the same if we look at the patient. The patient is laying there and it does not respond at all. What is the difference between stupor and coma? The stuporous patient can be waken up by a painful stimulus. So if you really apply pain, it will wake up. Whereas the comatose patient stays comatose, it doesn't matter what you do. And obviously, that's a scale that where the disease becomes more severe the further you are going down here. That's why it's important to assess the mental status. Whenever we observe any neurological deficits, we usually try to localize that deficit to a certain neuroanatomical structure. If you have a patient that has a reduced mentation, where can the underlying pathology be? Either in the brainstem or in the forebrain. I usually compare that with the forebrain is a light bulb and the brainstem, that's the switch. And if there is no light, either the light bulb is defect or the switch, one of two. It does not have to do anything with the cerebellum, but it has to be a forebrain or a disease of the brainstem. And then there is one other term that does not really fit into that scale, but it's a type of abnormal mentation. That's what we call delirium. So patients with a delirium, they are awake, but they do not respond in a proper way. The patient may be walking around without responding to the surrounding. The patient might be howling or barking continuously without reason. So it's an inappropriate behavior in an awake patient. The next thing we want to observe is the body position. And I have two things that we commonly observe. One of them is a head tilt. So the head is rotated, usually to the affected side. There's only one or two exceptions to that rule. And on the other hand, we have something that we call, it's a complicated word for me, pleurotonus. And that's in contrast to the head tilt, where only the head is rotated. It's a rotation of the entire neck to the side. Head tilt is usually associated with a vestibular problem on the lower side. The pleurotonus is usually associated with a forebrain lesion. So that's what I said before. If we see a deficit, we try to localize that right away to a certain area of the nervous system. Then we have a few more body positions we can see, especially in traumatized patients. Here we start with something you can already see that has a grave prognosis, what we call a decerebrate rigidity. And decerebrate means the connection between brainstem and forebrain is disrupted. And the reason why that has a grave prognosis. Those are patients that do not respond, they are comatose, and all of their muscles have an increased tone, resulting in rigidly extended limbs and opisthotonus, so overreaching of the neck muscle. If you see something like that following a trauma, it probably doesn't make sense to try to treat that patient further. A little bit different is what we call decerebrate rigidity. Here we have a problem between the cerebellum and the brainstem. The connection between the cerebellum and brainstem is disrupted. Those patients have a reduced mentation, maybe comatose, but they don't have to be comatose. They have rigidly extended front limbs, and that's different now to this cat, often they have flexed rear limbs. It's still not a good prognosis. I have written here poor, but it's not as bad as it is with decerebrate rigidity. And here's something completely different, because what we have here, it's called Sherrington Position, that happens after spinal cord trauma. Doesn't have to do anything with the brain. Those have brain disease. This patient has spinal cord disease. And that's why those patients have a normal mentation, because the brain is not affected. It usually happens following trauma. They are paraplegic, so the rear limbs are completely paralyzed, and we have an increased tone in the front limbs. I will come back to that later, how that develops, but we have to recognize it. A patient after being hit by a car, normal mentation, cannot move the rear limbs at all, and rigidly extended front limbs, Sherrington Position. It's usually a severe spinal trauma. When I studied neurology, it was said that the prognosis is grave in those patients as well. That's probably not as bad anymore nowadays, so I would call it poor. They can recover, but it's not very likely. We are still observing the patient, and what we can see on the gait, what we commonly see with different diseases, is ataxia. Ataxia is a lack of coordination. You could say it looks like a patient being drunk. It can affect only the rear limbs, or it can affect all four limbs. Lack of coordination. If we see ataxia, we have to be aware that different neuroanatomical localizations can actually cause ataxia. Most often we see ataxia associated with vestibular disease, and the reason for vestibular disease can be either in the ear or in the brain. But we can see ataxia with problems of the spinal cord or peripheral nerves as well. Then we call it sensory ataxia, and we can see ataxia with any pathology in the cerebellum. So the ataxia we have to recognize, and that helps us to define that we have a neurological problem, but it does not really localize it to a certain area of the nervous system right away. Then there is something else we commonly see, and we call that hypermetria. And we start with the left video here, because that is showing the problem quite impressively. Hypermetria, the patient will lift up the limbs higher than necessary. So it's flexing and pulling the limb forward in much longer steps than it's supposed to be. And that's a gait, even without being a specialist in neurology, something you can recognize. And if you see something like that, it always has a cerebellar disease. So hypermetria we associate with the cerebellar lesion. On the other hand, I have written hypermetria with a question mark, and I will try explain why there is a question mark. That's a park dog. And it's supposed to move. Here it does. So everybody can see what this park is doing with the front limbs. However, there is a significant difference between this dog and the park dog. On the left-hand side, this dog is flexing the limb and extending the limb. Flexing and extending. That's the cerebellar disease. What that park dog does is just lifting the extended limb up. And that is usually associated with a spinal cord lesion in the upper cervical spine. And that should really be differentiated. And to say it right away, if a park dog does show those clinical symptoms, the underlying pathology in the cervical spinal cord is usually what we call an arachnoid diverticulum. It's a local distension of the subarachnoid space. It's very common in park dogs. So, as I said, hypermetria, cerebellar disease. If it is true hypermetria, it has to be differentiated from the extended gait you have seen on the right hand side. Now, the hypermetria I have shown you before in this Bavarian mountain dog was quite obvious. It's not as obvious in this West Highland Terrier. And I believe it's more obvious in the rear limbs when the dog walks back now. So the first video I have shown you, everybody can recognize. But if you look at his rear limbs now, he's lifting up his rear limbs higher than he's supposed to. But it's not as obvious as we had seen in the other dog. Still, if you see something like this dog has cerebellar disease. Yeah? So sometimes you really have to take a while to watch your patients. If you do neurology, it doesn't matter what level, there's no way around that you have to take your patient to an area where you can watch it walking. So you cannot solve most of those cases just by placing the patient on your table in your exam room. You have to watch how the patient behaves and how the patient walks around. Something else we can see observing the patient. Those are different degrees of reduced voluntary motor function. We have two terms, paresis and plegia. Paresis means it reduced voluntary motor function. And I insist on the term voluntary motor function, meaning motor function initiated by the brain that has to be differentiated from reflexes. Now that's very important. So if it is decreased but it's still there, it's paresis. If it is completely lost, it's plegia, or some people say paralysis. Those are terms that can be used for both. And then you can add those little words here in order to describe if it's only one limb that is affected, for instance, monoparesis, or limbs on one side, so the left front and the left rear limb, then it would be hemiparesis. If it is just the rear limbs, then we would talk about paraparesis, and obviously if all four limbs are affected, it's tetra. So I like those terms because you can use 3 or 4 sentences to describe that this dog has still voluntary motor function, but 2 limbs are affected, 2 limbs on the left side, or you just say it has a left-sided hemiparesis. And everybody should know what you're talking about. Yeah? It gets a little bit more complicated because paresis and plegia, both of them can be subdivided in 2 subcategories. The paresis, where you still have voluntary motor function, can be mild, so the patient is still able to walk without your help, or it can be more severe, and this patient is not able to walk without your help anymore. Then we call it non-ambulatory paresis. And the plegia can be subdivided as well. The milder type, this patient can still feel pain you apply to it, then we call it a plegia with intact deep pain sensation, or the patient, and that's the worst status you can reach, the patient is not able to feel pain anymore, then it has lost the deep pain sensation. So we basically have 4 degrees: ambulatory paresis, non-ambulatory paresis, plegia with deep pain sensation, and plegia without deep pain sensation. And just by using those terms, you can already describe how severe the patient is affected. And we can use that as an example here. And you can decide what type of reduced motor function we have there. Does anybody want to comment on which degree do we have here? Paraplegia. Okay. Yeah, could well be. Do we know if there is remaining voluntary motor function? No.
We didn't check.
We didn't check.
Yes.
Yeah. So this dog could well have a non-ambulatory paraparesis as well. And it makes a difference in the prognosis. Doesn't matter what the underlying pathology is. So we have to take a moment to lift up the rear part and push the dog forward to see if there is still some minor motor movement left in order to determine if this dog is plegic, maybe even loss of deep pain sensation, which may result in euthanasia, or is it a dog that has a non-ambulatory paraparesis, which is much better. Yeah.
And probably yes, because it tried to put weight on knees.
Yeah, could be that there was already some indication that he can still move it. So all that happened more or less without touching the patient. And now we have come to the third part, which I call the hands-on neurologic examination. And I usually start with postural reactions. We are testing the patient's ability to detect where the limbs are in relation to the body and to perform a correct response. And there are different things that can be done. The most commonly performed is what we call the conscious proprioception test, or nowadays some people call it paw positioning, where we take the paw, we turn it around, and the patient is supposed to turn it back. Now, something is wrong in that image. Sorry? We cannot see the paw. That's already guiding the correct direction. Actually, our hospital director would have a very specific opinion what's wrong there. Dr. Flegel, that is not dressed appropriately. Yeah? So that's what he would say is wrong. But you are correct. The surface here is not suitable to perform that test. You cannot see the paw. There might be holes in the grass. So we should actually have a relatively plain surface. It should not be a slippery surface. I usually go outside onto those plates, and now we can perform the test. And it's very important that you support the patient. You more or less carry the entire weight of the patient, so the paw is just supposed to be on the floor. Why is that the case? We want to test if this patient has a neurological deficit. Let's assume that we have a patient that is very anemic, hypoglycemic, is very weak. can barely stand on his 4 feet. And now you lift up one paw, turn it around. This patient is not able to perform the correction because he or she would have to stand on 3 limbs for a second. That doesn't work. But we do not want to know if that patient is weak or not. What we are testing is, can the patient actually feel that the paw is in the wrong position? And that's why we should actually support more or less the entire weight. And here I have a video that is illustrating that. So in standing position, the person doing the examination is standing behind, supporting the weight, and that works in the front limbs as well. The hand is now here. And just repeat it once or twice in order to see if your result is repeatable. And within 1 second, the paw should be placed back in the correct position. So if I give a talk like that to clinicians in Germany or to my students, what commonly happens, even though I have explained the way it's supposed to be, if we train that, half an hour later, something like that happens. It may work in many patients, but it's not the way it's supposed to be done. You're supposed to support the patient. It probably doesn't make a difference if you have a completely healthy patient. But patients that have a neurological problem or a metabolic disease, here it may make a difference if you find out if the nervous system is affected or not. Everybody knows that cats are different. Yeah. So many cats don't want their feet to be touched. And there's obviously at least one alternative, what can be done in cats. And we still test, in this cat, actually it does work, but in majority of cats it does not. And what we can do alternatively is we move the paw against the table. It's important that you cover the eye of the cat. It's not supposed to see, but the eyes are covered and it should feel when the paw is touching the table and then it's putting it on the table. You can do that in a dog as well. It's not limited to cats. And you have to decide if you want to lift up a Great Dane, but I usually only do it in cats because they don't weigh more than 5 kilograms and they usually don't want their feet to be touched. You are evaluating similar anatomical structures as in the paw positioning. It's just a different way to do that. And there are other tests that we routinely perform in order to see if the patient can detect where the limbs are and can place them in the correct position. That's one of them. So the animal should not fall down when all the weight is put on the front limbs. It can be made even more complicated if you extend the neck. So if this animal breaks down in the front limb, something is wrong. In this case, the patient should walk backwards in order to come into a normal horizontal position again. Hopping on one limb. If this animal is falling to the side now, then something is wrong. This dog should be able to bring this remaining limb under the body in order to maintain the weight. So as long as this dog is able to walk on 4 limbs, it may compensate minor deficits. But if you force the patient to do something on one limb, you may detect those minor deficits. And especially if you have a left-right difference. If it works very well to one side, but it continuously falls over if you test it to the other side. So you are testing the ability to detect the position in the room and to perform the appropriate correction. Cranial nerves. My God. Who remembers all the names of the cranial nerves? Difficult. Yeah. There are some sayings you find in the internet how to remember those names, and I believe it's not appropriate to mention those here because most of them are made in a way that they cannot be quoted. Yeah. But some
mnemonic.
Yeah, yeah. But somehow we have to test those nerves, even if you don't know those names. I guess we still remember that the nerves more or less leave the brain in the area of the brainstem. Meaning, if we test those nerves, we test usually one sensory nerve, then the information goes to the brainstem, and the response comes back with a motor nerve. So we more or less have tested two nerves in the brainstem, as a general rule. There are a few exceptions, which I have listed here, where the forebrain is involved as well. But as a general rule, cranial nerve testings are testing two nerves and the brainstem. And unfortunately, we have to go through those tests. You see on this image that a few of those nerves are not highlighted anymore. Those are usually not tested in a routine way. And the main reason is because there is no reliable test available for those. We start with a Menace response. Menace response is one test to test vision. And here I have a video again, how we recommend performing the test. Usually the observer is standing in front of the patient. One hand is covering the other eye that is not tested, and then you make a fast movement to the eye and you want to see how the eye is closed.
But, sorry, may I tell something? Usually I use not flat palm just to avoid to create any airflow.
Yeah.
Just with rib.
So I just repeat it once more since I don't know I'm still there now. It's better now, yeah. So if you know what I have said that, many people say that you should not move your hand in a close way because the air that is directed on the eye may actually be enough to close it. In my opinion, that's not true. If you have a blind patient, it doesn't matter how fast your movement is, if your hand is closed, there is no Menace response. That's my experience, and I believe that it's not necessary.
Maybe my palm so big as fan.
Yeah, maybe, but in my opinion, it doesn't matter. Yeah. What is important is that you do not touch any structures here. That you do not.
Battery, probably out of battery.
Maybe if somebody can try to ask. I will try to see if it works until we get a new one. So I believe it's not as important. But you don't have to touch the whiskers or the eyelids. Then you can actually elicit a response even if the patient is blind. In cats sometimes it's, I don't know, one step back. I believe it's really important that you cover one eye, the eye you are not testing, because there's quite an overlap of your visual field between those eyes. So this side could be blind. But if I make a fast movement with the hand, I see the hand coming with the other eye that is not blind. So cover one eye, and usually, as I said, stand in front of the patient. You can fix the head if you grab around the mouth and you have covered one eye. But sometimes it's more helpful if you stand behind the patient, cover one eye. Important is that one eye is covered. And what are we testing here? Obviously vision, the second cranial nerve. The information goes to the brainstem, but then it goes to the forebrain as well. I have to see, I have to recognize my hand. It's a real response. It's not a reflex. That's why we do not call it Menace reflex. We call it Menace response. And it's something we have to learn during life. It takes about 2 to 3 months. So dogs and cats, that are younger than 2 months may not have a Menace response, because you have to hit the wall a few times in order to recognize that it's better to close your eye. Yeah? It's a response we learn. And then the answer to close the eye, that's coming back with a facial nerve. So basically, whenever you do something facial, it's a facial nerve. Yeah? The facial nerve is responsible for everything you make with your face. That's why it's a facial nerve. So Menace response, optic nerve, brainstem, forebrain, and the facial nerve. For some reason, the cerebellum is involved here as well, but that's more the deeper neurology. Something else to test vision is a pupillary light reflex, and we will see the video in a minute, but I will explain what I believe is important. We shine light into a pupil, and what we want to see is a constriction of the pupil. Patients in our examen room are very excited. They have a high sympathetic tone dilating the pupils, and they are scared. They are afraid, and it's very difficult to get those pupils constricted until you use a real good light source, and you have to hit. Thanks. And you have to hit the most sensitive part of the retina in order to get a good response. And most of us intentionally, if you test the pupillary light reflex, if I would be the patient now, we shine the light into the eye that way. That's what we usually do. The most sensitive part of the retina is lateral in the retina. And in order to hit the lateral retina with my pen light, I have to direct the light from the nose lateral to the eye. So I believe that is important. At least if you do not get a response in the normal way, then redirect your light from the nose lateral to the eye to see if there is a response. And that's the way it looks like then. So if the pupils are not dilated yet, you cover the eye for a moment in order to dilate them, because a small pupil cannot constrict anymore, obviously. And then from the nose to the lateral part of the retina. What are we testing there? Yeah, obviously we test the function of the eye itself. Then the optical nerve, the information goes to the brainstem and comes back with another response. In this case, in contrast to the Menace response, the patient does not think about the response. It's a real reflex. As long as the brainstem is functioning, you get a real reflex, and the response is coming with the oculomotor nerve. Do you have to know those nerves? Not necessarily. I believe if you do not do it on a routine way, you should have a checklist. What tests do I have to perform? And if you find a deficit, then you can look up which structures are involved there. So you do not have to have all that in your mind, but you have to know, or you have to have a checklist, which steps of the examination do I have to perform. Cotton ball test. The cotton ball test is a very general test to see if the patient has a vision, but it can be quite helpful. In my opinion, there are again a few, I believe it might not be the battery. There are a few things that are important. I usually stand behind the patient. If you are standing in front of the patient and you do something already, the patient, if it is not completely blind, will follow you. This cotton ball is supposed to appear suddenly as a surprise in the visual field of the patient. And that's why I usually stand behind, and maybe another person is in front. Drop the cotton ball laterally. You want to test if the left or the right eye does not work. If you just drop it in the middle, and as long as one eye is working, the patient will see the cotton ball. So thanks. Do it laterally. And I have a patient for you, actually, where it does not work on both sides. So especially if you have a significant left-right difference, we already see that on the left-hand side there's no real manner response, whereas on the right-hand side she is blinking. And now we take our cotton balls. Actually, that's not the perfect way. The person should be standing behind. On the left hand, on the right hand side, she is responding, repeated several times. So if you see a left-right difference, then it's probably true. If the patient does not respond at all, especially if it's a cat, it may just mean the cat doesn't want to play with you. But if you have a difference between left and right, then it's probably a true finding. Palpebral reflex. That is again something that can be done wrong in a palpebral reflex. What we want to do in the palpebral reflex, we want to touch the eyelids and the eye should be closed. And if I come with my pen to use this way, you probably already close your eye before I already touch you. So we have to avoid that we test vision. And one way to do that is not coming from the front, but coming from the top. And you can test it on yourself. You do not see this pen if you come from the top. You really test if the animal can feel that you are touching it. And that's why it's important to perform it that way. And that's what we have here. Again, I usually fix the head by grabbing the nose. And we test it on the medial and on the lateral canthus because there are different branches of the trigeminal nerve involved. And the eye should be closed, more or less completely. So what are we testing there? We already know who is closing the eye. Everything we do with our face is the facial nerve. So the response is a facial nerve. Whenever we touch the patient anywhere in the face, doesn't matter where it is, it's usually the trigeminal nerve that is a sensory part. It's a true reflex, goes to the brainstem, so we test the trigeminal nerve, sensory, the brainstem, and the facial nerve. Palpebral reflex. Corneal reflex. We carefully, and it's important probably to say carefully, touch the cornea. You can take your fingers if they are clean, you can take a Q-tip, but we are touching the cornea and the normal response would be the retraction of the eyeball. And that's the way we do that. So you take two fingers, you open the lid, and that sometimes really requires a second person because one has to hold the patient, and what we want to see is how the eyeball is retracted. Sometimes you do not see the retraction, but you see the short flip of the third eyelid, which is a positive response as well. We have already learned which sensory nerve we are testing there. Whenever we touch the patient in the face, it's a trigeminal nerve. Yeah? Now the retraction of the eyeball is a different one now, and that's the sixth cranial nerve. It's a true reflex again, going through the brainstem. So trigeminal nerve, brainstem, and abducens. Nasal sensation, it's another thing. Nasal sensation, and again, you're just sitting in front of me, that's why I have to use you. Yeah? So nasal sensation, we carefully touch the nasal septum, but if I come to you that way, again, you probably already pull your head away before I touch you. That's why it's important that we cover the eyes. So we are not testing vision here. We are testing the ability to feel that I test the nasal septum. Okay, grab the nose, use the same hand to cover both eyes, and then only slightly touch the nasal septum. And the normal response would be exactly that. You pull your head away. It's not a reflex, you really make a movement. Why is that important that it's not only a reflex? Because in order to perform a complex movement, you have to use your forebrain as well. In this case, we are not only testing a cranial nerve in the brainstem, but we are testing the forebrain as well. So let's create a scenario of forebrain disease. A patient with a forebrain disease could potentially have a normal palpebral reflex, so you have tested the trigeminal nerve, it's working very well. But if you test the nasal sensation, it does not respond. You know that the trigeminal nerve is working, because we have tested it before. The conclusion is, this patient has a forebrain disease. And I have an example here illustrating that. In this case, it's unilateral. It's a cat. So, same story, cover the eyes, no response. There she is reacting. If that happens, just see if that is repeatable. So, especially if you have a left-right difference, you know that it's not just a patient that does not want to move because it's sitting on your exam table. It would, if it would feel it. So that is very likely, if the palpebral reflex was there, forebrain disease. Physiological nystagmus. Physiological nystagmus obviously has to be there. It's physiological. And when do we develop a physiological nystagmus? Whenever we move our head. We get some rhythmic eye movement. That makes sense, and we will talk about that when we talk about vestibular disease. So, what we do, we just move the patient's head. And then we watch if we get a rhythmic eye movement. It is easier to recognize if you lift up the eyelid and if you see the white sclera. I'm not sure if it will come closer in a second. If you can see that, there is a rhythmic eye movement. That's physiological nystagmus. We usually test that in the horizontal plane, but it can be tested in the vertical plane as well, but as a routine, we test it in a horizontal way. Now, as you can see there on the top, there are several nerves involved. On one hand, there is a vestibular system with a vestibulocochlear nerve that tells us that we are moving. Whenever we move, the vestibular system tells us. And then we have three nerves that are innervating the extraocular muscles. And as you can see there, it's 3, 4, and 6. And I can already introduce you to that idea, even though I come back later to that. You probably still remember from school that. Do you still know?
Sulfuric acid.
Yeah, sulfuric acid. We have something similar. LR6, SO4 times 3. 3 nerves, 3, 4, and 6. And that is supposed to be a help to memorize which nerves are involved in moving the eyes. And I will come back to that and explaining exactly how you can memorize which muscles are innervated by those 3 nerves. But if you already try to memorize LR6, SO4 times 3, you already know that 3, 4, and 6 are involved in moving the eyes. Physiological nystagmus, there is a light version, at least I call it the light version. So for cats or small breed dogs, it's usually more helpful if you lift them up and you turn them in front of you. And you can easily see if they are moving the eyes or not. Yeah? Again, you can decide what the maximum body weight for you is to perform that test. Segmental spinal reflexes. We are nearly at the end of the neurological examination. I believe you will not read that term segmental spinal reflexes anywhere in any textbook. I insist on segmental spinal reflex because if you keep that in mind, we remember ourselves that we are testing certain segments of the spinal cord. Segmental spinal reflexes of the front limbs, they test that segment C62. Segmental spinal reflexes of the rear limbs test segment L4S3. Segmental spinal reflexes. In contrast to poor positioning or reaction, because some people mix those things. They call those conscious proprioception reflexes. They talk about reflexes when we talk about spinal reflexes, and at the end everything is mixed up. Segmental spinal reflexes, they are testing a specific segment of the spinal cord. And here we have the segmental spinal reflexes I will be talking about. In the front limbs, I like the extensor carpi reflex, the flexor reflex, and in the rear limbs we have those reflexes. You will find more reflexes in textbooks, but I believe most of the other ones are not very reliable. What do I mean by reliable? The other reflexes I have not mentioned here, you will not find in every healthy dog. And if you cannot elicit the reflex in any healthy dog, then it is not really helpful for patients that have neurologic disease. That's why I would favorize the ones I have listed here, and it starts with the extensor carpi reflex. And in the extensor carpi reflex, the normal response we expect would be extension of the carpus. Why do I say that? Because in order to be able to extend the carpus, it has to be flexed. Quite often I see that the test is performed in a position like that, and there's no way that it can be extended anymore. Yeah? So start with a flexed carpus. How can you flex the carpus? By flexing the elbow. So just flex the elbow of the patient and you automatically flex the carpus as well. Yeah? That's easier than just trying to push the carpus down and it comes back and it comes back. No, flex the elbow and you get a flexed carpus. And here we have the test. The limb is lifted up from the floor because as long as it's laying on the floor, it may not be able to move. For muscle reflexes, we use the tip of the reflex hammer, and you really have to hit the muscle. It's different in tendon reflexes. In tendon reflexes, where you hit a tendon, it's usually enough just slightly to touch the tendon. If you hit a muscle, you really have to do it with some power, and then you get an extension. And it's not more, the extension is not larger than what you have seen here in the video. It's just a mild extension. And we are testing the radial nerve. It's probably more important to know that we test the spinal cord segment where all the nerves are taking off in order to supply the front limb. So all segmental spinal reflexes of the front limbs test the spinal cord segment C62. Flexor reflex. Flexor reflex, especially in the front limb, is actually testing several nerves, and we do not try to differentiate between all those nerves. Patient is laying on the side, and we test the upper side, and I usually take the skin between the digits and I press the skin between. And what we want to see is a flexion of all joints, and we want to see that that happens with an appropriate power. Appropriate meaning depending on the size of the patient. So it's not only enough to pinch the toe and the animal is pulling the leg away. I'm usually holding it a little bit to see how much power is there. Because there are certain neurological diseases where the reflex may still be intact, but the strength is reduced. That can already be abnormal. How do I know that the strength is reduced? Yeah, unfortunately, you have to perform it several times in normal dogs in order to get for yourself a normal. Then you can compare the results in other patients. The patellar tendon reflex, that's probably the one most of us are familiar with. It's a tendon reflex now. So that means we can only slightly hit the tendon. Patient is laying on the side, limb is lifted up from the floor. Now we use the white part of the hammer, not the tip, and we hit the patellar tendon, and we want to see one extension. And that's okay. That's a normal response. Lift the limb up from the floor, otherwise it cannot move, and touch the patellar tendon with the white side of the hammer. Here we are testing the femoral nerve. In the rear limbs we try to differentiate a little bit between the nerves. In the front limbs there is so much overlap that it doesn't make sense, but in the rear limbs it would be good to know, or you have to look it up when you have deficits, but it would be good to know that it's a femoral nerve. And it does not stop here. Whenever we talk about a nerve, you should try to memorize where it comes from in the spinal cord, and that's quite easy in the femoral nerve. The femoral nerve comes from L4, 5, fix. Yeah, everything that starts with an F. That's the patellar tendon reflex. Then we have the cranial tibial reflex in the rear limb. It's a muscle reflex again. Means we have to take the tip of the hammer and we have to hit it really. What is the supposed response is a flexion of the tarsus. So don't support the limb here because that's supposed to move. You can take the tibia, the tip of the hammer, and hit the cranial tibial muscle that's slightly below your knee on the lateral side. Yeah? Here we tend, sorry, I have to take the Latin word. It would be easier if I would have written the English version, the sciatic nerve. The sciatic nerve starts with an S. That means the sciatic nerve comes from the spinal cord segments 6, 7, and sacral. Yeah? The femoral nerve 4, 5, 6. The sacral nerve 6, 7, and the sacral segments. We are nearly through. Flexor reflex in the rear limbs, that's basically the same as in the front limbs. You pinch the skin between your digits and you want to see an flexion that is appropriate to the size of the patient and test not only the existence of the reflex but the strength as well. We are nearly at the end. Paniculus reflex. Paniculus reflex is a reflex where we slightly pinch the skin on the back and we want to see a contraction of the skin muscle. The reflex arc, the way it works is if you pinch the skin here, there are little tiny sensory nerves that bring the information to the spinal cord. It's traveling all the area up to the lower cervical spine and there is a nerve leaving the spinal cord and innervating that muscle. And it's very helpful with focal spinal cord lesions. What can happen is you pinch the skin here, no response, no response, no response, no response, because the information cannot traverse that area here. But suddenly you get a response and you get your reflex. So if you have an area where you do not have a reflex behind, but you get a response in front of that area, you may have detected a focal spinal cord lesion. Be aware that there is no paniculus reflex caudal to your iliac wings. So it just does not exist in most patients there. So you start testing those patients somewhere in the iliac wings. If you get a good response there, then you know the entire reflex is working. Then there is no need to test it further cranially. But if you do not have a response in the caudal area, then you test slightly, go cranially, until you get a response. And that's the way it can potentially look like. Usually I stand up the patient, but it's not necessary. I take hemostats and I slightly pinch the skin. It's not supposed to be painful. It's just slightly pinching the skin. Unfortunately, I believe it's still getting closer, the video. And now you can see the response. Now, if you get one in the area of the iliac wings, you know it's fine, you don't have to test it further cranially. Here I have a video where it is lost on one side. I saw it. No, it's not that video. Sorry, I made a mistake. It's there on both sides as well. The very last step, and I intentionally do that at the end of my examination, is to see if the patient is painful. Because if it is painful, and you do that at the beginning of your examination, you may not be able to perform all the other tests anymore because you have pissed off your patient. So that's why it's done at the end. And why is that important? We already talked about this cascade a little bit. I said that in patients, I should say probably in patients with spinal cord lesions, we have different degrees of reduced motor function, paresis, plegia, and at the end, the worst thing that can happen is that we lose our deep pain sensation. That's why it's so important to test that. The prognosis becomes pretty poor. How do we test deep pain sensation? I take my hemostat and I really apply pain to one digit. So I take my hemostat and I take one digit between and I really press hard to see if the patient can actually feel pain. How do I know that it does feel pain? It's not about the flexion of the limb, because that's a segmental spinal reflex. The question is there a mental response? Is there a screaming? Does the patient turn around? I usually say if the cat is biting you, then it's good, because the cat has deep pain sensation. Yeah? It actually can be done for spinal cord disease, but it can be done, and I have, no, it's not what I wanted to show. Okay. Deep pain sensation, let's stop once more. Deep pain sensation was about detecting pain, especially in spinal cord disease. Independent from that, we want to know if a patient is painful. And I usually test pain in the thoracolumbar spine in a different way than in the cervical spine. In the thoracolumbar spine, I get the patient up, I put one hand underneath. In this case, it's not in order to support the patient, but sometimes you may, as the only symptom of pain, you may feel, if you have your hand here, how the muscle tensing. Now you get, suddenly you feel how the abdominal muscle tension changes. I extend the tail to see if there's pain there. And in the cervical area, there's so much muscle around that putting pressure on the muscle doesn't help you. I usually flex and extend the neck, and then I bend it to the left and to the right side. For most patients that do not have pain, you can actually turn the neck around 180 degrees. You can basically touch the thoracic wall with the nose without any resistance. How can I detect pain? Yeah, either the animal is resisting that movement, you can't just not bend the neck anymore, or it's screaming out in pain. Yeah. So much about the neurological examination. Are there any questions so far? Yeah. Sorry. Maybe use a microphone then.
So, actually I have a question about the hypermetria which you showed the video in the beginning. I couldn't really get it, like the types of the hypermetria, like the one which you showed first and the second one. So I have a bit of confusion, like how I'm going to diagnose, how I'm going to differentiate between these two types.
Yeah. So it was about the two types of hypermetria. I will try to do it once more myself.
Yeah, please.
Maybe it sounds, maybe it looks silly, but if it helps you to memorize it, then it's okay.
I was going to say that.
Yeah. So cerebellar disease, it's usually very high lifting up and a wide range of motion, much higher than necessary. Flexing first, then extension. Flexing first, then extension. What the other dog did with a cervical lesion, with the extended, it's moving with extended limbs, like a soldier would march. Yeah, does it make sense? Cerebellar disease, flexing and then extension, flexing and then extension, and the other dog just walks like that without any flexion. That's the cervical lesion. Yeah?
Do we get a paradoxical panniculus reflex, whereby we get a cutoff, and then after that we get a little sensation?
Do we get a paradoxical panniculus reflex? I hope I understood you correct. Here it is. So what I said before is either you have a normal reflex all the way up, or you have no reflex, then here it starts. What I have not discussed is that there might be an area reflex, then loss of reflex. That's what you are referring to. Very rarely, if that happens, it's not really compatible with a spinal cord lesion. It can happen if the sensory nerves leaving the spinal cord here are affected. But with a spinal cord lesion, either you have a normal response or you have a cut-off with nothing behind and normal before. So only with a focal sensory lesion outside the spinal cord of the sensory nerves, it can happen. Yeah? Let's start there. Want to use a microphone?
Yeah, thank you. We haven't speak about like testing cranial nerves, specifically the 10th nerve or nervus vagus. Yeah. So how much important is, for example, having like tests like a gag reflex or like oculocardial reflex by testing nerve vagus, or how much important in the practice would be? Thank you.
Thanks for the very last part of your question, because that's the easiest part. How important is that in general practice? Not at all. How important can that be in specialty practice? There are a few cases where you have vagal nerve deficits, where you may have accessory nerve deficits, but it's very rare that you get isolated deficits of those, and then we probably will have to go to a textbook, but I probably get a question like that, and I am only doing neurology once every 3 or 4 years. So that probably tells you how rare that condition is, that you really need that knowledge.
In human medicine, maybe it's more important.
Could be.
Yeah. And okay. Okay.
Well, thanks so much. Just I want to clarify my doubt. Maybe it's related with this subject. We are the things, the nerve fiber as being covered by the myelin, it's a fatty substance. It to transfer the nerve signal. If it gets affected, so how shall we come to know that the myelin has been, what is that, totally is disturbed or not enough myelin? So it's possible to come to the, conclusion it has been not completely, covered.
I'm not sure if I completely understood the question.
The nerve fiber has been covered by the It is useful to transfer the nerve signal.
Yeah. So
if it gets affected, how shall we come to know particularly because of this myelin?
So I try to repeat your question if I understood it correctly. The myelination of nerves, that is obviously affecting the function, but it's only affecting the function in the sense that it does reduce the speed of transmission. So there are certain diseases which are very rare, I have to tell you, certain diseases that interfere with myelinization. Those patients usually have sensory deficits. You may have a more or less normal motor function, but if you test things like conscious proprioception or hopping, you get delayed responses. They can actually have reduced reflexes, not because they're not strong enough to perform it, they just do not feel if you pinch the skin. So usually you have a relatively normal gait, but you have changes in proprioception and you have changes in testing of the segmental spinal reflexes.
So is there any particular test related to this one, Doctor?
Particular
Test related to this one?
here doing our no, not in detail now. We will talk slightly about neurolocalization of the peripheral nervous system, but that really goes into detail, because then we talk about electrodiagnostics to measure the nerve conduction velocity, how fast can a nerve transmit information, and that's already very detailed neurology, and that's maybe next time.
Thanks a lot.
Yeah. So sorry, the next person was there. Then come.
It's a very common. I just want to ask, how can I differentiate between upper motor neuron or lower motor neuron? Because sometimes it's just it's confused, so I just need a golden point. That's it.
Can I answer that question in the next talk? And if I did not, then you ask once more. So, one more question.
Yeah, just it's that T1C8 on the
Yeah, yeah.
What is C8?
That's a good question, yeah.
It's C8.
Good question. I heard sometimes if somebody responds to a question by saying it's a good question, he does not have the intention to answer. Yeah, but there are actually 8 cervical spinal segments. There are only 7 cervical vertebra, but there are 8 segments and 8 cervical spinal nerves. And whenever neurologists talk about something like that, they usually refer to segments and not to nerves. Yeah. Okay. Yeah.
Actually, we talked about reflexes, and in most cases we talk about checking if there is reflex or no reflex. But in some cases, especially for example the patellar ligament reflex, where we have another situation where we have that what's called over reflex, which has another complete meaning. Is it correct?
Yeah. Increased reflexes. We have not talked about increased reflexes, and that belongs in the same category as your colleague asked. I would like to address that in my second talk. Yeah? Yeah.
Just going back to the nasal sensation part, when you said that the lesion was in the forebrain, like localization, was it contralateral or was it
The question was about nasal sensation. If you have loss of nasal sensation and it's not the trigeminal nerve but the forebrain, the lesion is on the contralateral side. Yeah.
This vestibulocochlear nerve. So we didn't talk about it, and it's sometimes very difficult to test.
Yeah, because there is a separate talk today about the vestibular system. Yeah. So you obviously you ask all the questions where the answers come a little bit later. So I have to ask you to be patient, and I hope I will address your questions. Okay, let's come to the next talk. It's Belgrade. We're not in Belgrade right now.